So we are ready to start our second session on EMR and reimbursement. So we have three papers. The first, we have Healthcare Outcomes, Information Technology, and Medical Reimbursements by Danish Saifi. Then we have the adoption of EMR systems. Do they inflate Medicare reimbursements by Karthik Ganju? And finally, does IT enable revenue management in hospitals by Kang Ki? So without much ado, let's begin.
Thank you, Dr. Menon. Good afternoon, everyone. I'm Danish Saifi. I'm a doctoral student in the Information Systems program of the Business School in UT Dallas. This is a joint work with my advisor, Dr. Indranil Burton. I'll begin with the motivation behind our work. So, after PPACA Act was implemented in 2010, we have been seeing a transitioning period from a fee-for-service payment model to a healthcare industry which will be dominated by pay-for-performance. Given this transition, we focused on a period from 2011 to 2013, which was still predominantly focused on fee-for-service payment model. Now, after PPAC was enacted, the penalties which will be set in will be coming into picture from 2014 onwards. We expect to see a leading effect of those penalties in our study period. I'll discuss more about that as I move on. Another aspect of the reimbursement story is how we expect health IT usage to impact average reimbursements from payers, including Medicare. So in this study, we propose a unified framework which includes all the three key variables, that is average Medicare reimbursements, healthcare quality measured as readmission rate and mortality rate, and health IT usage at hospital level. We focus on only heart failure patients so that the idiosyncratic factors that might be present at different DRG levels don't affect our findings. So, beginning with the hypothesis, in our first hypothesis, we argued that hospitals with higher mortality rate are more likely to receive lower average Medicare reimbursements. Let me explain the motivation behind this hypothesis. As I said, Patient Protection and Affordable Care Act was enacted in 2010, but the penalties had started showing up from 2014 onwards predominantly. So when the penalties were designed, in essence, we expect the reimbursements offered by Medicare to hospitals will be a function of the hospital's health quality outcomes measured as readmission rates and mortality rate. So what we expect is the period before 2014 and after 2010, which is our focus period, we expect to observe some kind of leading effects of that tie-up with the quality. So in essence, we are proposing that hospitals with higher mortality rate are more likely to receive lower average Medicare reimbursements. The second part of our first hypothesis is that hospitals with higher readmission rates are more likely to receive higher average Medicare reimbursements. This basically is a reflection of the predominance of fee-for-service payment structure across the healthcare landscape in the United States, even now. Now moving on to the health IT side of the story. We argue that hospitals with greater health IT usage are more likely to realize higher average Medicare reimbursements. So why do we argue this? We expect that hospitals with higher level of health IT usage will be able to make their overall reimbursements and claims process more efficient, thereby realizing more revenue from Medicare and other payers. But over here, we are focusing only on Medicare. Let me further elaborate. Consider a hospital which has implemented some health IT systems such as EMR, CPOE, and structured physician documentation. Such a hospital, compared with hospitals which doesn't have any IT system, will be able to better capture the diagnosis codes from the clinical side of the hospitals. The systems will then be able to streamline the information flow between clinical department and the administrative department. Further on, the information flow between the administrative department and the payers, including Medicare, will be further streamlined, again because of the health IT systems implemented between hospitals and payers. Given this streamlining and seamless flow of information flow between the clinical department, the administrative department hospitals, and the payers, we expect to see an overall increase in the average reimbursements or reimbursements per discharge. Now, to further understand the dynamics between health IT usage and average reimbursements from Medicare, we also try to explore or investigate whether there are any mediation effects of health quality outcomes measured as mortality rate and readmission rate. I'll delve deeper into that story, after a few moments. So this is the overall conceptual model that we have examined in our study. The first one essentially tells the two sides of the story between health IT usage and average payments for Medicare. Now, coming back to the exploratory question of whether we expect to see any mediation effects of health quality outcomes on the relationship between health IT usage and reimbursements, what we propose is that health IT usage is likely to impact health quality outcomes, and health quality outcomes in turn are likely to affect average payments from Medicare. Now, in previous studies, there have been lots of disagreements in terms of whether health IT actually has any kind of effect or whether it's positive or negative on health quality outcomes measured as length of stay, mortality rate, readmissions, and more than that. So what we find actually in our study is, as we expected, that we found weak partial mediation effect of mortality rate on the relationship between these two variables, but we didn't find any effect of readmission rate. I'll delve deeper into that further on. To investigate our hypotheses, we collected data from multiple sources. The three key variables in our study came from Medicare inpatient prospective systems. That basically gave us the average reimbursements from Medicare. We collected data on mortality rate and readmission rate from hospital compared data sets, and we collected information on the variables that helped us construct health IT in our study from HIMSS data set. Now, to construct health IT systems in health IT usage in our study, we averaged the values of enterprise EMR, CPOE, and structured physician documentation. Beyond these variables, we controlled for hospital-level effects, hospital-level attributes such as case mix index, whether a hospital is rural or urban, the geographical location of the hospital, meaning whether it's in Atlantic region, Mountain Pacific region, or the Midwest region, and also other attributes like whether a hospital is academic or not, and the ownership status of the hospital. So I don't want to go through these things in line by line. What I'm trying to say over here is the base model specifications in our study are pooled OLS and hospital random effects with time dummies. The rationale behind hospital random effects with time dummies is that it's not very unreasonable to assume that the hospitals have been across the country have been pulled out randomly from the population of hospitals, whereas the observations across time for each hospital are likely to be correlated in some manner. Now, these are just the descriptive statistics of our data set. Again, I want to remind you, we focused only on heart failure cases. So as you can see, the average payments or the payments, Medicare payments per discharge for heart failure, major complications and comorbidities, just one DRG varies from under $7,000 to over $35,000. This is just our data set, panel data set comprising of 540 hospitals across United States. Then we also find some amount of variation in mortality rate, readmission rate, and also health IT usage. Now, these are the results of our model specifications. I want to draw your attention towards the cells that have been highlighted in green and yellow. So let's start with mortality rate. As we had hypothesized, we found that hospitals with higher mortality rate are likely to receive lower average reimbursements from Medicare. When it comes to health IT usage, we found as we hypothesized, we found that higher health IT usage leads to or is likely associated with higher Medicare reimbursements. But this statistical significance became marginal significance when we deployed random effects, hospital random effects with time dummies. The p-values are between 0.1 and 0.2. Okay? Moving on to readmission. As we had hypothesized, we found that hospitals with higher readmission rates are more likely to receive higher average reimbursements from Medicare. And like we found in mortality rate, we again found positive association between health IT usage and average Medicare reimbursements. Now, just to go a little deeper into the coefficients and what they imply, if any hospital is able to increase its health IT usage by 1 standard deviation, that's approximately 23.79%, that hospital will be able to realize an increase of approximately $180 per discharge with that increase. Okay. Now, these are the mediation effects results. So to examine the mediation effects of mortality rate and readmission rates, we deployed Sobel's test, and then we further tested the robustness of Sobel's test using Goodman statistic and Erwin statistic. So again, I want to draw your attention to the cells that have been highlighted in blue. We found that there is only a weak partial mediation effect of mortality rate on the relationship between health IT usage and average Medicare reimbursements. The p-values are between 0.15 and approximately 0.2. As we had expected, we didn't find any kind of mediation effect of readmission rates on that relationship. Now, the rationale behind that, anything that might disincentivize, in a fee-for-service payment structure, anything that disincentivizes a hospital to go for low readmissions will be something that they'll try to stay away from, right? So if we had seen any kind of effect of health IT on readmissions and a further effect of readmissions on the average Medicare reimbursements, then that value, the p-values over there also would have been somewhere between 0.1, 0.2 or less than 0.1. But as I said, anything that disincentivizes hospitals to go for low readmissions in a market structure which is dominated by fee-for-service payment model will not be showing up in our results, and that's what we came across. So, just a summary of our major findings. We found that hospitals with higher mortality rates are likely to realize low average reimbursements, whereas hospitals with higher readmissions, admission rates are likely to realize higher average Medicare reimbursements. We found that health IT usage is likely associated with higher average Medicare reimbursements for the implementing hospitals. And as we expected, we found weak partial mediation effect of mortality rate on the relationship between health IT usage and average Medicare reimbursements. Now, there are several limitations in our study. One of the biggest limitations is that we have used the hospital level data set. So if there are any confounding factors that might be present at the patient level or the visit level, the effect of those confounding factors may or will not show up in our results. Okay? This is particularly true for studying mediation effects, because the variation of the effect of health IT on patient mortality or readmission and the further effect on the reimbursements per patient, that is much better studied at the patient level or the visit level rather at the more aggregated hospital level. Further, these results may not be generalizable to private payers because our focus payer was Medicare. And we also focused only on heart failure, so these findings may not be applicable to, say, for example, pneumonia or myocardial infarctions either. Now, just to end my presentation, there are several implications of our study, not only for policymakers, but also for consumers, meaning patients, for payers, and healthcare providers, including hospitals. Because ultimately, the new system that is coming in, meaning PPAC penalties, this is not only going to affect the supply side, meaning the hospitals or the payers, but also the consumer side, meaning the demand, right? So even though we have focused primarily on the supply side, this study has potentially further extensions, where we can further explore not only the supply side, but also the consumer side. Thank you very much.
Okay. Good afternoon, everyone. I'm Sharon Tan. It's always good to be back at White. I look forward to this trip, even though it's a very long flight and it's about 12 hours time zone difference. And thank you all for the conference organizers to invite me to be a discussant for this paper. I really enjoyed reading this paper by Danish and Indranil because it addresses a very important and timely issue. As we've heard this morning, I think the medical system in US is moving. By the way, I'm not from US, so I'm also learning about the US medical system here. So I think you're moving from a fee-for-service system towards a value-based system. And as the authors have pointed out, prior studies have actually looked at more focusing on health outcomes and healthcare costs in terms of the impact of health IT. But in that study, they're actually looking at reimbursements, average payments, and the mediating role of health IT through healthcare quality. So they talk about effectiveness as well as efficiency arguments. And also like the fact that they had created their own data set from 3 different sources over a 3-year period. Don't know if you mentioned this, but they actually had lagged the health IT data by a year. So you can actually see that the HIMSS data set is actually a year earlier than the outcomes data set. Also, they have done, as you can see in the presentation, very robust, rigorous analytical analysis and have consistent results across the analysis. Okay, so this is their research model. I won't go into detail about this. So just some comments that I have about the paper. So first of all, the paper was motivated by this idea of movement of FFS to a VBR kind of a model for reimbursement. And what I kind of found when I was reading the paper is that this is really interesting, but I think a lot of the hypotheses were going between a fee-for-service versus a VBR kind of argument. For example, H1A was actually using a VBR perspective, whereas some of the other hypotheses were using a fee-for-service perspective. So I thought, it could lead to some confusion, and perhaps the authors could consider sort of streamlining their arguments so that it's either one or the other. And also one of the hypotheses, like H2, is actually not really related to fee-for-service, where you're actually looking at the impact of health IT directly on reimbursement. So I think this is probably a more of a positioning kind of issue, but I think the authors can probably work on this. Second issue is, second suggestion or comment is the idea behind medical payment and hospital costs. One of the contributions I've pointed out in the first slide is that they are focusing on reimbursement rather than costs as the outcome variable. But some of the hypotheses, as I realized, they've kind of used cost reduction as a rationale for why they should behave in a way to increase reimbursement. And the authors have also done a very good job in terms of explaining in that paper that costs, reimbursement, and costs are not the same thing. Okay, because the last 2 bullets are actually taken from that paper itself, because sometimes there are elements of strategic negotiation or there are some kind of comprehensive contracts that results in disalignment of cost and reimbursement. So I thought perhaps another thing is to think about trying to use more of a reimbursement argument to explain why the behavior of the hospitals are as such. Okay, and some of my final few points are related to a more clear explanation of the underlying mechanisms behind the hypothesis. The first set of hypotheses, H1, H1A, and H1B, as I kind of looked at the rationale behind why hospitals are behaving in this way, it seems to be that they are driven by the reimbursements that are given. So they are trying to act in a way that they can actually get more reimbursement. For example, if I can actually treat more patients, do more services, I can actually increase my reimbursement. So reimbursement actually seems to be driving behavior rather than the other way around. So I was wondering whether the authors would perhaps even consider whether they could put reimbursement as an independent variable and maybe looking at IT usage as an intermediate variable, in the sense that hospital behavior is actually the outcome rather than the independent variable. Okay, and regarding H3, this is the hypothesis that argues that IT has a mediating role on reimbursement. And again, the authors argued in their paper that the link between health IT and health quality outcomes, meaning mortality rates and readmission rates, there has been quite a bit of mixed findings in the literature. So I hope they could maybe explain the black box a bit better in terms of why they argue that in their paper they expect to see a positive relationship. And I thought it was interesting because they had data looking at different types of IT systems, EMR, CPOE, as well as documentation. Maybe you can argue it more in terms of how these systems actually influences the outcomes, and perhaps maybe also consider running your analysis based on individual systems rather than than kind of aggregating them together, because I think the different systems will actually play a different role. And for second hypothesis, I think the authors mentioned that this is more of an efficiency argument. So I just wanted to suggest maybe to drop the effectiveness argument, because then it would actually make your storyline a little bit more confusing again. Okay, last point. Okay, the last point is about association versus causality. I don't know if the authors were trying to be strategic in terms of focusing more on association rather than saying that this is a causal effect, because they actually have longitudinal data, 3-year period data, and they have lagged IT by a year. So in actuality, there is actually a causal effect. Also, the model seems to suggest that there is a causality, but they have actually said that they are focusing on association. So I wonder if maybe a longer period of time of data would actually help get sort of more of a results that focuses on causation rather than association. Okay, that's it. That's all I have.
Okay, so good afternoon. My name is Karthik Ganju. And today I'll be presenting my paper, which looks at if the adoption of EMR systems is associated with inflated Medicare reimbursements. This is a co-authored paper with Hilal Atasoy and Paul Pavlo, and we're at the Fox School of Business at Temple University. So generally there's been a support for the adoption of these systems from government via the passage of HITECH Act. And this was motivated by the belief that these systems would sort of reduce costs and it would improve quality. My dissertation essentially looks at some of the unintended consequences of the adoption of these systems. So in one of my other papers, I look at what happens to neighboring hospitals when hospitals adopt EMR systems. And in this paper, we looked at the phenomenon of upcoding. Now, there's been sort of conflicting evidence in the literature. There have been a couple of papers that have looked at this. And we sort of try and use a larger panel, a longer panel. And we use the quasi-natural experiment that sort of is implemented during the duration of our panel to sort of suggest mechanisms about why there can be these conflicting results. Also, we sort of use it as a mechanism to rule out alternate explanations. So what is upcoding? Upcoding is a process by which, so when patients are sort of diagnosed or treated, they're placed in diagnosis-related groups, and hospitals are reimbursed on the basis of which DRG they place the patient in. So these are two DRGs that deal with respiratory ailments. So one is without complications and comorbidities, or major complications and comorbidities. In 2012, it was reimbursed at a rate close to $5,000 average rate. And if you were able to document that it had major complications of comorbidities, you got a reimbursement, the hospital got a reimbursement of a rate that was close to $8,000. So basically, upcoding deals with strategically placing patients in more complex DRGs to sort of qualify them for higher reimbursements to the hospital. Now, the CPOE system is essentially a system that's been sort of argued that could lead to upcoding taking place. The computerized physician order entry system basically allows physicians to electronically store and share data with different providers, and as well as record symptoms of patients and test results. And it's had a couple of positive effects. There have been a couple of studies that have looked at this. It's shown to have greater adherence to guidelines-based care, a reduction in medical errors, and basically some studies have shown that physicians prescribe more appropriate doses after the implementation of these systems. So it is like the CPOE system has had many positive effects. Now the question is, does CPOE facilitate upcoding? So what the argument is that CPOE systems often come with built-in auto-population systems or templates for helping physicians record information for patients. And it's intended as a mechanism to to reduce the time that physicians take in storing patient documentation. The concern, however, is that these templates can actually include keywords which can then qualify the patient for a higher placement in a higher DRG, or it can sort of extract data from other sort of sources and represent that data to allow these patients to be placed in a higher DRG. So Sanyal has this example where he sort of argues that when these systems were implemented, it was able to pull social history of patients from another data source to make it look like this social history was discussed during the interaction with the patient, when that may not have been the case. And this richer information in some cases can sort of be used to file for higher DRGs. The main dependent variable that we use is the case mix index of the hospital, and I'll sort of explain what it is. But what we argue is that the adoption of CPOE is correlated with a higher case mix for the hospital. Previous research has also argued that for-profit hospitals are more likely to indulge in practices that are similar to upcoding. And this is basically because there are institutional objectives for for-profit hospitals to be sort of maximizing their reimbursements or their revenues. The arguments behind this is that hospitals essentially consist of two structures. So there's an administrative side and there's a clinical side. And in for-profit hospitals, there's actually more alignment between the objectives of the clinical side with the administrative side. And this is done by getting physicians onto the board of for-profit hospitals by offering them equity in the management of the hospital. So there was a hospital in Florida that was sort of bought over by a for-profit chain. And over 1 year, it sort of, the number of people the proportion of patients that it reimbursed in, I think it was respiratory ailments, increased from 31% to 76%. And this proportion actually jumped to 90% over the course of 2 years. Whereas the hospital down the street, there was no effect. So there has been previous research which has sort of argued that for-profit hospitals show evidence of practices in line with upcoding. However, the evidence about this is mixed. So basically, we look at if CPOE adoption in for-profit hospitals is having this effect or not. The third issue that we look at in our paper is a recovery audit program that was instituted during the duration of our panel. So it was basically instituted by Medicare by contracting with 4 auditors across the US as a mechanism to sort of check what was happening and check claims that were submitted to Medicare. The statement of objectives very clearly said that the recovery auditor may issue denial when the submitted service was upcoded. And in 2010, 2 out of the nation's 4 auditors actually listed upcoding as one of their main sort of concerns that they were encountering when they were checking claims. So we sort of look at this audit program as a quasi-natural experiment that takes place during the duration of our panel. And we argue that this evidence of upcoding may actually be moderated by the presence of this audit program. So just to quickly give you an overview of the data, we use the HIMSS data for the CPOE adoption. The case mix data, we actually concentrate on Medicare. So we look at IPPS files, inpatient prospective payment system files. We use US Census data for socio-demographic data about the county that the hospital is located in. And we use Medicare cost reports for hospital operational data. And we developed this panel from 2004 to 2011. And this is what we do our analysis on. So we use, as a main dependent variable, we use the case mix index of the hospital. Each DRG is assigned a relative weight. So here I've got 2 examples of DRGs. So the first one is if you got a heart transplant or heart assist technology. and that was given a relative weight of 25, whereas if you had a respiratory infection, you were placed in a DRG that had a weight that was closer to 1. And the way that you get this case mix is you sort of average the relative weights across all your different patients. And that essentially is our main variable of interest. The empirical specification that we use is pretty standard. We use a fixed effects model. We control for the presence of other systems. We sort of check if there's collinearities that are appearing there as well. We include hospital fixed effects and time fixed effects and cluster errors by hospital and year. Okay, so these are the main effects. Essentially, does CPOE show evidence of a higher reporting of case mix index? And even when we include other controls, such as the presence of other systems, we actually find that it does. So these are the average effects across all hospitals. When we break it down by for-profit hospitals, we actually find that the effect of these systems is statistically significant in for-profit hospitals, but on average, in non-for-profit hospitals, there's no statistically significant effect. Additionally, what previous research has argued is that these practices may not be just limited to for-profit hospitals, but may actually be present in other hospitals that are co-located with for-profit hospitals. So we do sort of a hospital market level analysis, and we look at the number of for-profit hospitals that exist that are co-located inside a hospital referral region. So what we find is if there's a not-for-profit hospital and it's co-located with a number of other for-profit hospitals, it actually shows greater evidence of using CPOE to sort of increase the case mix that it has, or its CPOE presence is actually correlated with a higher level of case mix in the hospital. Okay, next we come to the audit program. What we find is that when the audit program is not in place, there's a positive and statistically significant effect. However, the presence of this audit program actually has the potential to moderate this effect of a presence of CPOE leading to a higher case mix. Now what actually happens is that 2 out of the nation's 4 auditors actually develop capabilities to identify copied and over-documented records. Over-documented records is essentially the use of templates for documenting patient records. The question is this capability actually going to have a greater impact on a lower case mix of the hospital? And we actually find that if a hospital adopts CPOE and it's in an audit region where the auditor has developed this capability, it actually shows a negative and statistically significant impact on the case mix of the hospital. However, if it's not within these, it actually does not have this effect. So what are our implications? We find implications in line with upcoding. However, the audit program and specifically the capabilities of auditors have the potential to moderate this effect, and this could be partially the reason why we find mixed effects in previous literature. We find that additional payments using the effects that we find, using back-of-the-envelope calculations, we find that the adoption of CPOE is associated with higher reimbursements of $298 million against total payments of Medicare Part A that were $136 billion. And additionally, what we find is that that there's actually this sort of, when the incentives of the financial side and the clinical side of the hospital are aligned, we actually find that there is a greater impact on upcoding. And they're stronger when there's less demarcation, essentially, between the financial and clinical objectives of the audit, of the objectives of the hospital. And on average, we find that the audit program has the ability to moderate the effects of upcoding, and specifically, the abilities of the auditors have the ability to moderate this effect of upcoding. Thank you.
Okay, I'll just take you 2 minutes of your time. So I'm Wendy Du. I'm from George Washington University, so I'm local. My campus is only 10 to 15 minutes drive from here. It's a great pleasure to read this paper, and also Kartik has been very meticulous in sending me the papers and the slides, which allow me to sort of read through the whole things. I have no expertise in this area, so for me this is a very interesting learning experience. Just by reading the title and when I first got the paper, I'm very intrigued because I think as Kartik mentioned and also many other presentations today, we have seen a relatively large body of research and discussions talking about the impact of adoption of EMR systems. Most of them are talking about how great is the EMR system in terms of helping reducing the cost and improving the quality of the service. But they are really actually, this paper, this study, taking a very different angle and looking at the unintended effect of EMR system adoption. So I'm just quickly summarize of the paper. So this paper looked at the effects of adoption of EMR system, particularly the CPOE system on upcoding. And ultimately that would actually imply the inflation of the overall reimbursement cost. So the analysis is a fixed effect estimation, and they also very nicely designed, taking advantage of the gradually rollover of the auditing program as a perfect external demand shocks for the quasi, to set up the quasi-natural experiment settings. And Kartik actually didn't present this in the paper. They also conduct various of robustness tests to rule out the alternative explanations, the endogeneity effect, falsification test, and also handle the reverse causality. So the results does show a significant more complex patients coding after adoption after the adoption of CPOE system. And I think this has potentially significant policy implications in terms of the overall inflation of the Medicare system. We also have heard a lot in the news about the worries and discussions about our Medicare systems. So some thoughts, I even reluctant to say this is comments and suggestions. Again, this is just some thoughts came into my mind while I was reading this paper. I'm very intrigued by the difference between for-profit and non-profit hospitals. And the results actually show that there's significant difference. And the results also show that the non-profit hospitals would somehow influenced by the for-profit hospitals if they're located in the same areas. So I'm just wondering maybe they can look into a little bit more nuances of their data to see if there's any spillover effects among nonprofit and for-profit hospitals, and not only between for-profit and nonprofit hospitals, but also the inter-hospital effects, whether such spillover effects carries from hospitals to hospitals, because we have seen a lot of cases transferred among different hospitals. And also the paper mentioned that CPOE is just one of the EMR system adopted by many of the hospitals today. There are many other systems that actually work with CPOE system. So it will be, I'm curious about the sort of interactions among different EMR systems. How would they ultimately also influence upcoding and the ultimate reimbursement cost? And also, I was discussing to one of my friends about this. This is a question I had, maybe a very naive question. I noticed that the paper, and along with many other papers, mostly use Medicare cases, Medicare data, because it's probably publicly available. Also probably accounts for a large chunk of the expenses for the hospitals. So this is just a naive question I have is, do we also look at the other cases, like normal population cases, in compare and contrast with the Medicare cases? And lastly, I would say that maybe they want to, because they have 7 years of data, so maybe a dynamic panel data setting would help to establish more causal relationships, because the current mixed case index may be highly correlated with next time period. So more dynamic settings may be more helpful in terms of establishing the causal relationships. So that's it. Thank you very much.
Hi, good afternoon, everyone. My name is Kang Chi, and I'm a PhD student at Michigan State University. I'm happy to be here today to present our work on the impact of IT on the revenue side, revenue management in hospitals. So this is a joint work with one of my committee members, Dr. Krishnan, and also two co-authors from the University of Michigan Dearborn and Harvard Business School. So just to try to give you a quick overview of this study. So this paper specifically studies the association between the adoptions of IT systems and the revenue management